We are live. Good afternoon, everyone. I'm Cory Busse. I'm the Vice President of Strategy and Sales Enablement here at Icario. I am joined this afternoon by my friend Andy Lee. I'll let him introduce himself.
Good morning or good afternoon, everyone. My name is Andy Lee. I'm a sales executive here at Icario.
And we are sharing this afternoon a webinar that we fondly refer to as Feedback Matters, Why CAHPS is Still King, emphasis on the still. Because with the myriad changes that have undergone CMS over the course of the last several months, there's a lot of priorities that are competing for your time and attention, and we thought we would spend a little bit of time on breaking down a handful of things related to CAHPS, specifically how they affect star ratings. I don't think that's any mystery to the folks on the call this morning, but we thought we'd do just a quick baseline. How pre-CAHPS surveys, in our experience, can help, and where health equity fits as a key component of where you're progressing between now and 2027, when things really get serious related to the health equity index in particular. What we've learned through our own pre-CAHPS analysis. We'll get into the multiplicity of pre-CAHPS surveys that we have done for clients with dozens of thousands of members, and have contributed to our overall data lake and analytics that have shared some insights that might surprise you with regard to pre-CAHPS surveys and other types of insights that might be precursors to member satisfaction. And then targeting strategies and how you can start to have an impact on 2025 CAHPS right this very minute. As I mentioned, I'm Cory Busse, Vice President of Strategy and Sales Enablement. Been with Icario for about 6 years, and come from a background in health plans, PBMs, pharmaceuticals, medical devices, and most recently, the last decade or so, health tech. So a lot of experience here in the health plan and government programs space. And as I said, I am joined here by Andy Lee, who's a sales executive here at Icario as well. We wanted to just sort of baseline on what it is that we do here at Icario that kind of gives us some perspective into what we're about to talk about here this afternoon. And it's not to turn this webinar into a sales pitch at all, but rather to establish some subject matter expertise in the area, particularly related to the data sets that we have access to as a result of the kind of work that we do with health plans like yours. So we are the leading health action company. It is not enough to simply engage members. Moving members from engagement to action is key to what we do, and we are awfully good at it in a couple of different ways. Because we deeply understand people, we bring insights from a host of different industries that you might not normally think of when you're thinking about how do I do member engagement to a health community and a health plan, in particular in government programs. We are able to reach further and deeper into your member populations than maybe perhaps you are yourselves, with either limited resources or limited experience with regard to member engagement, to overcome barriers and make really personalized outreaches to your membership. And overall, we like to say we communicate with people like they're human, which is sort of the aha no-brainer. But we tend to speak with members in channels that they choose, in language that is most familiar and comfortable to them, to compel them past engagement into action. We do that in, as I say, primarily in government markets. Medicare Advantage, D-SNP, and Medicaid will be focused, obviously, in pre-CAHPS, which has the greatest application right now in Medicare Advantage and D-SNP, obviously. We work with more than 20 Blues plans, 8 of the 10 largest plans in the country, in all 50 states and north of 100 million member lives. And we're able to generate this measurable value for health plans in such a way that shows them for member retention, medical cost avoidance, and risk adjustment purposes. Programs that we deploy and the types of insights that we glean are able to help health plans recognize in your revenue in terms of these overall metrics. All of that, like I say, is not meant to establish a pitch for Icario, except to say that because we have done these types of programs for so many health plans in so many memberships, it has given us an expansive data lake from which we can draw various insights. So what we're talking about here are a multiplicity of queries that we have done to our own data platform and have come back with some insights, as I say, that might surprise you as we go along. Andy's going to ground us in a little bit about what about why CAHPS is still king, why CAHPS is still a primary consideration for you, and what some of the steps that you can take to address them in the near and longer term. Andy.
Great. Thank you, Cory. Well, let's start off with the bang right away here. That CAHPS is 30% of your star ratings. And up till last year, it used to be a lot more. 30%. Not 1%, not 5%. 30% of your members' experience is what rival or determines your ultimate quality bonus payment and your star rating. Why that ultimately matters is that members who are satisfied are 5 times more likely to renew their insurance coverage than their unsatisfied peers. And we know members who have a positive customer experience and are much more active with their engagement, and that leads to higher retention. Now, as you think about other different industries with strong loyalty programs, Delta SkyMiles, Starbucks, Southwest Airlines, even Sephora, people continue to go back because of the experience they have and what they know to expect. Now, we think about that from a Medicare Advantage standpoint. We know that 75% of a population is in a 4-star plan rated or above. If you don't have a good experience, you're going to fall below that 4-star rating, and those members are going to look to go somewhere else. It makes it vital. It makes it extremely important to understand what is going on in that member's head. What is the psychology that they're experiencing in their experience in order to increase that satisfaction? Ultimately, a member who is actively engaged, who is aware of what benefits they have, and is willing to take the time to be part of their overall healthcare problem, is going to have a higher attendance of their annual wellness visit, which is going to close 4 more gaps on average compared to their peers. So not only are you dealing with the psychology of how a member feels, how they think, how they act, you're getting that downstream HEDIS impact to further increase your overall star ratings. Now, this is the big difference with CAHPS, right? And this is what probably everybody knows, but we're going to say it out loud. Psychology here is what drives that satisfaction. I just mentioned this a second ago, right? How a member thinks, how they feel, how they act is going to determine how they respond to that survey, right? And this is the power of self-reported data. And we've seen CMS take a much more stronger position on self-reported data being stronger than clinical data, because it's really telling the true story underneath of what is going on within each individual member's life. What are they experiencing? What are the struggles that they're dealing with, right? Not always can a claim file determine what has changed from yesterday to today in a member's life. It could be loss of a job, it could be loss of a spouse, could be something new in their life that's changed. CAHPS is able to get there the next step level faster, that allows plans to understand what is the experience their members going through and be able to engage with them. Ultimately here, we're looking to make sure that that first experience, that second, third experience with a member is positive and encouraging. We want them to feel supported. You want them to feel empowered and cared for. You don't want them to be confused, right? Because they're going to keep calling in. You don't want them feeling frustrated because they're just stop caring. They're just going to be negative and drown you out and other noise they're dealing with. Focus on other things. We want them to stay with you. You want them to spread the word about their experience and get them to respond positively to the CAHPS survey. Now, on that last bullet point, we know this year that CMS, for the first time ever, introduced a digital survey option, right? This is the first time ever in CMS history. And as we've all been accustomed now with COVID the last few years, we've seen digital adoption largely increase across all different types of businesses, all different types of industries. This means now that we expect a higher amount of members to participate, which can be good or bad, depending on how you're experiencing with those members. Now, as we think about the timing here, I will say it's kind of a short window, but it really is, right? So you have 6 months from beginning of the year where you can't understand who they're reaching out to, what members are dealing with, right? How they're engaging with the health plan based on what the CMS blackout period is. And now come July, which is hard to believe it's already July 10th here, you have less than 90 days-ish in order to understand what can you impact in that experience and their satisfaction, help keep them stay with you during that annual enrollment period. So now you're fighting an uphill battle to get in front of October, in addition to what can you change next year for your health plan? Now the bid's been submitted, you can make some changes, but you're really fighting for what is going to happen next to that CAHPS program, and what can you do in the next 6 months to engage those members, to understand their challenges, understand opportunities within your provider network, your pharmacy networks, to help make sure that that member experience is put to the top and that satisfaction continues, that members coming back on that survey saying, yes, giving 10s, right? Staying high in that overall 8 through 10 ranking and not dipping down to a 3 through 1. Now, Cory's going to go on here in the next few slides to talk about what else does a pre-CAHPS help with.
So a lot of plans use pre-CAHPS or mock CAHPS surveys to identify who's unhappy at the individual level. The value of the non-anonymized nature of the survey is that it can get to the heart of members' barriers to care and dissatisfaction with your membership. You can identify specific areas of weakness and you can correct those proactively, ideally before, as Andy pointed out, AEP, but it requires rapid analysis and turnaround of the program while the mock CAHPS survey is going on. Well, it is not enough, and we see this all too frequently in our experience, where a health plan will make the decision to execute a pre-CAHPS survey of some stripe and will execute the pre-CAHPS survey, wait for the data to come in, do the analysis, concoct a program design to address potential dissatisfiers, and then deploy it, which, to Andy's point, is a really steep hill to climb or a really hard task to accomplish in the 90 days between when the blackout period ends and AEP begins. So the approach that we take instead is to help identify proactively who's dissatisfied, identify where those members are dissatisfied, and use the CAHPS and satisfaction program in concert with the real-time data exchange between Icario and our health plan clients to make proactive outreach and campaigns out to members who have raised their hands and said, I'm unhappy about A, B, or C. We can also compare those the results year over year to determine who is dissatisfied and leaving the plan, which is its own problem, but also identify those members who might be dissatisfied and likely to stay, which is a different kind of problem, because those members are likely to persist. And if they show up as dissatisfiers in one CAHPS survey, they may persist in their dissatisfaction and remain members in your health plan, sort of spreading that dissatisfaction potentially to others. We all know the old axiom that, you know, if someone's happy with the service they receive in a given consumer environment, they'll tell 3 people. If they're unhappy, they'll tell 9. It's the nature of a pre-CAHPS survey in order to identify in real time and early enough to intervene those members who are dissatisfied, so you can convert them from dissatisfied to satisfied, from detractors to promoters. In addition, there is a long-held dissatisfier on the part of health plans themselves that say that you get painted with the experience members have with their provider. And unfortunately, that is 100% true. The experience members have with their health practitioners is something that the health plan ultimately gets blamed for in the CAHPS survey. So early identification of cohorts of physicians who might be contributing to your members' dissatisfaction, resulting in perhaps a provider scorecard, can also be early indicators to help you proactively address dissatisfiers well before it will show up on a formal CAHPS survey. Just as a baseline on how we execute member satisfaction and retention programs, in this case example, and I won't belabor this, but in this case example, we learned about which areas within the CAHPS survey were causing issues in a large Blue Cross Blue Shield plan. We targeted the populations here with rewardable activities, with that sort of ubiquitous rewardable activity that cemented positive member experience and created a benefit-focused, rewardable learn and earn activity to educate members on spots that had shown up as problem areas within their CAHPS survey. We even worked in a few HOS-related areas, a topic near and dear to Andy's heart, HOS-related activities to ensure that members had something to talk about with their providers once they arrived into, say, an AWV setting, and that they remember, because of the reward and incentive and the fact that we had prompted them to have these conversations, that they remembered that they talked about it with their provider once the Haas survey rolled around, which, by the way, the Haas survey kicks off next week. We measured our success by comparing the member retention in the population that participated in our program compared to the H contracts members choosing to leave the plan. I think it's C26 this year. So that percentage representing that is represented in their star ratings. And in programs like these, we outperformed the plan's overall retention by about 36%. So retention programs work. Another key feature as to why CAHPS is so critical going forward is the introduction of the Health Equity Index and the bonus that's tied to it. If anybody on the call knows anything about CMS, they start with the carrot and they move to the stick. So that Health Equity Index bonus today will become a requirement with downside in the future once it's perfected or cemented in CMS's minds. And so, as Andy referred to before, the Health Equity Index has really brought self-reported data to the top of the list. And we'll talk more in a minute about how self-reported data can be a strong indicator of member satisfaction beyond the CAHPS survey. In the most obvious case, your CAHPS survey results, like other surveys, like your health risk assessment or your new member surveys, can help you baseline your socioeconomic and demographic data with a few common questions that aren't going to surprise your membership. As you can see in the timeline here, beginning with the service dates right now in 2024 and implemented with 2027 star ratings, we're in that critical benchmarking and tracking phase right now. What you're learning now through your CAHPS surveys and other surveys should help you progress toward more equitable delivery of care and develop targeted interventions aimed at reducing disparities in your membership population. When we reach 2027, the Health Equity Index will reward plans that demonstrate improved outcomes in members who have social risk factors. And as we go forward into our presentation, pay close attention to some of the findings we talk about later. Your members who are most likely to have social risk factors are the very members who are telling you that they're dissatisfied with their plan. Low ratings the dissatisfiers that I just mentioned are often thought to be related to things like the provider network, like we talked about before, or less robust benefits. But there are a lot more fundamental issues that are better predictors of member satisfaction and that are actionable way upstream from your CAHPS survey. What you're about to see is that successful plans don't compartmentalize CAHPS. They treat CAHPS and member satisfaction not as an event, but as an interconnected process. And that has tentacles into every single interaction your health plan has with a member. Andy's going to share with you next some of the things we've found when we ask multiple questions of Icario's data lake.
Great. Thank you, Cory. So what have we learned throughout all of our programs, right? So Icario's been doing pre-CAHPS surveys for many years on top of health risk assessments, new member surveys, value benefit, the list goes on and on. There's three stats here I want to focus on right away before I get into sort of what are the three large themes that we generally see year over year with our different surveys. So number one, minimal engagement is needed from members, right? Members are willing, they're able to give that engagement if you ask them. 3 outreaches or less. So our programs work in an omni-channel orchestrated event so that we ask members across the different channels to get them where they're at to give you that response. So there's no really member abrasion here asking someone, hey, how do you feel? How's it going? Tell me how you're doing. And the beauty of that is that 86% of those members completed the entire survey question. And these questions on average range from 10 to 40. You're getting members to tell you intricate details of their experience, telling them when and where, right? How things are going, what their challenges are, what the good things have been as well. Not to say that everything is bad, but understand where are those moments that you can highlight as well in areas of improvement. 52% of those members all say that their experience would be better with better plan communication. So as we focus on those three things, right? Members are giving feedback. They're giving it all the way through with minimal outreach requirements. They're coming across with 3 different categories. They're often associating their health plan experience with their primary care experience. And we'll talk about that in a second here. Non-English speaking members often report that customer service does not treat them respectfully, right? As we talked about just now, and a theme that you're probably picking on, that self-reported data, we know that race and ethnicity questions are coming up more and more. And we know what a member puts on an application isn't always exactly 100% true. Being able to have that level of information is going to improve those experiences. And finally, tying into what CMS just announced for the final rule for starting 2026, keep me honest there, Cory, is members being dissatisfied with supplemental benefits, right? There's a reason CMS has instituted that you have to notify these members, but it's more than just you offer them, you need to do it. It ties to the monetary value and the impact CAHPS behind it. So as we go into this next slide here, there's two other things here as we think about self-reported data that continues to show up. Activities of daily living. And as Cory noted earlier, the Return of Health Outcome Survey starts this year, next week. Now, it was paused because of COVID. There's been rumblings about the activities of daily living being part of that survey, but CAHPS is already sort of doing it in a way that can give you that next level information to take that action on a member. The key point I want to make here is if you look on the screen and you see the Medicare only, third box on the right there, that first box, members with reported 2 struggles of activities of daily living are at least twice as expensive for those with just 1. Twice as expensive, right? For something as minor as needing help changing, something as minor as transportation, right? Little things that are already offered with your health plan that members can take action with, but they don't know how to. In addition, social determinants of health, something that's been talked about multiple times the last few years with how do we engage, how do we interact, how do we create intervention because we know there's hard dollars tied to that reduction. If within CAHPS surveys, not only can you find out where a member is struggling, you can find out other information about them that's increasing their dissatisfaction, decreasing their experience, and removing their engagement. Increasing that engagement will reduce your cost by 11%, we estimate a year. Overall, what we're looking at here, again, as the bottom box talks about, is the psychology here. If a member perceives they have poor negative health perception, increasing that will reduce your healthcare costs by at least 5%. And as we talk about the next few slides here, what we'll get into is sort of the data intelligence that Icario is offering. So with the CAHPS survey, it's randomized. It's not specific to members. You get back just numbers and you have to deal with it. The beauty of our reporting is that specific to the member that we reach out to, the member's response rate. So you know that Andy Lee said this about you. It's not anything that's being hidden. It's not anything that's being told. Well, good luck figuring it out. With our survey responses, we get into who is that member and how are they responding that allows for that next level engagement with a health plan or Icario. This, in essence, allows you to better understand where are those challenges, where are those opportunities, where are those good stories to highlight, right? Not everything's always negative. There are good things that come out of CAHPS surveys. So how do we take advantage of that? So these next few slides you'll see are just a few different case studies that we've done or data points that we've established. But before we get into each slide here, we meet with health plans up front to understand where are those challenges within their CAHPS measures, where are those challenges, so that when we do reporting and insights, we're offering unique insights to that plan and not telling them stuff they already know. We work with plans to understand that what is that next action they need to take in order to increase their CAHPS, increase their satisfaction, and offer up different solutions to make sure they're meeting those at. So going back to what I've heard said 2 or 3 times now, I think, activities of daily living and that impact and health perception, right? We believe that in the next few years, this will become a HOS measure. But right now, CAHPS is able to capture that information up front. Sometimes this can be done with health risk assessment as well. We know members that report any sort of need with daily living, bathing, dressing, eating, grooming, mobility, will often have a 20% likelihood of having a positive overall health perception. That's one little thing, right? One thing here, it can be multiple, but based on where those members are at in that journey, getting them to get those supplemental benefits that can help them with some of these things is going to change their health perception, right? It's going to change their psychology of how they feel. And it might be just a simple tool they need to help get something around the house. Or if it is sort of just transportation or whatever those things are. There's easy minimal intervention techniques here to help address these things. As we move on to the next slide here, and again, sticking with health perception. If a member has a daily living challenge, right, they're going to have a negative health perception. If they already have that negative health perception, that's going to bleed into their rating of the health plan because they're sitting there at home, right, thinking about, I'm not getting the help that I need. No one's helping me out. What is my health plan doing for me? We know that members that are in that good to fair rating are 2.5 times more likely to stay there and give their plans a 3 out of 10 rating versus those that would ultimately give up that 8 to 10 and increase that rating. So understanding the psychology of what a member is going through, understanding these little data points that can be monumental changes in your CAHPS scores because of health perceptions are easy things that you can digest, take action on, and get engaged with that member to help drive them back to a positive environment.
And just to put a bow on the last 3 slides that as Andy has talked about them, ADLs have a significant upward trend on healthcare costs. More ADLs equals higher cost to a member. More ADLs have a negative impact on individual member health perception. And lower individual health perception reflects back on the health plan when it comes time to assess the plan for member satisfaction. What that key takeaway is, and this is what we were talking about before, is that CAHPS as a monolith, CAHPS as a moment in time is important, but there are upstream precursors that you can see in activities of daily living through new member surveys or pre-CAHPS surveys that can better inform the likelihood of member dissatisfaction for variables that aren't going to show up necessarily in a 1 to 10 scale on a CAHPS survey.
Thank you, Cory. And now moving on to the next thing here, we talked about this earlier, right? Dissatisfied members based on their primary care experience, right? That is correlated to the health plan, not to the provider office, right? If a member's waiting more than 15 minutes, that's the health plan's problem. If my mom can't see her doctor, but they can do it via virtual, that's the health plan's problem. We need to stop making those sort of changes to educate members on why their primary care experience can be better. And so we know that members who have that negative experience with the providers is going to give a negative rating on the health plan. Again, that's psychology, right? Their experience has caused them to think a certain way. It's caused them to feel a certain way. And to Cory's point earlier, they're 9 times more likely to tell other people about their bad experience versus the 3 times of being positive. We want to keep the positive momentum. In addition, we also want to understand where are those different areas in which provider offices or your network are having challenges. Is it located within a certain area? Is it a common theme within a certain demographic zone? That's the next level type of information that we want to track down and provide to you to help change those provider agreements, help change those provider conversations, and make sure that your members and your network are strong and satisfied all the way through. And as we talked about earlier too, 52% of members said that their experience would be better with primary care communication, better primary care communication, right? Often we hear the story a lot that doctors are being rushed in and out. They're not easy to understand, right? Different shots, different medications, different places to go, all those things. It's a lot. It's confusing. And unless you have someone there scribing it for you, it's a lot to take away alone as an individual. Again, as we think about the previous slide and we think about the responses members are giving here, we want to understand these things so that we can get to those primary care facilities and help them understand where those challenges are. And at the same time, if there's the ones that stand out where they say, yes, we want to learn from those primary care facilities about what they're doing so we can use that as best practices. We can engage with different members. We can engage with different clinics around what is that messaging that's working? What is that process flow, right? These are things that matter when it comes to expanding that network, to driving strong relationships and ensuring that your members are using the healthcare utilization the way it was designed for them.
And again, to bring home the last 2 slides, the value of something like a provider scorecard as a direct result, a cohort of membership that is seeing a provider group or an individual provider can be critically important to improving downstream member satisfaction so that at either the individual provider level or the provider system level, health plans can take concrete action in order to improve the areas of dissatisfaction that members are experiencing. So the value of a provider scorecard on which you can take immediate or real-time action based on member feedback is critical to improving downstream CAHPS scores.
And now the next one here, we talked about customer service, primarily based around the language component. And now, while most of our experience has been on CAHPS, the Medicare side, we've had conversations with plans on Medicaid regarding that. And the one thing we see often is that English is less than the 5% of the preferred language. But even with Medicare's alone, right? Understanding your members who are non-English speaking, or maybe it's their caretakers, right? And they're translating, whatever that might be. we know that understanding that specific language is a barrier, and that's creating tension, right? We hear it from a few different areas in which trying to help navigate that provider network to go see and establish a PCP versus always using the ER, for example, right? Understand those different languages, that's self-reported data. And Icario's platform can offer up to 30 different languages to allow members to engage where they're at and to be able to report back where their challenges, right? And to Cory's point just above, with the provider scorecard, right? That can help understand if there are different challenges when it comes to language within different provider networks, different areas. It can help your customer service team better understand how those different languages are impacting their ability to best serve those members. When we call in and we want to talk to someone, we often want to make it 3 easy steps, right? Understand the problem, resolve the problem, ask if there's anything else here. Being able to understand that language barrier is key to making sure that members feels cared for, they feel supported, and they feel empowered, knowing that if they call back again, they're going to get the right answer that they need to take that next care of action in their health. So all that being said, these are just a little glimpse of some of the data insights that we pulled from the years of service we've done on Pre-CAHPS. I'm going to let Cory over here talk about the different targeting strategies so that we're understanding when you think about those different barriers, those different gaps or challenges you have within your CAHPS scores, how are we going after the right members that are going to give us the right responses in order to help solve those problems?
So when the population getting the official CAHPS survey is this thin, anonymized sliver of your population, finding the members who will be the ones who make or break your star rating can kind of be like looking for a needle in a haystack. And trying to be all things to all members can actually be prohibitively expensive. But we have some recommended approaches in the direction that we take that we share with our clients that have proven really effective when we tackle member engagement. First is the beginning with how we target CAHPS members. And we start with identifying all of your new membership. That may seem obvious, but obviously the members who have no experience with your health plan are actually the most likely to churn out of the plan and show up negatively on a CAHPS score. So cementing that relationship with new members, like Andy said previously, making sure that that first interaction that a new member has with your health plan isn't in the frame of utilization management. No, you can't see this doctor. No, you can't have this drug. No, you can't have this procedure. But rather, some sort of positive experience that cements the relationship and actually forges something positive with the member, between member and plan, prior to any kind of intersection with utilization management is actually key. And that begins with your new members. In addition, identifying again in a non-anonymized fashion, you know the members who have called in with a complaint, whether they called in your customer service line, whether they've lodged some sort of formal review of your utilization management criteria. Members who have called in with a complaint or formally offered up a complaint to the health plan are odds-on favorites to be dissatisfied by the time that the CAHPS survey rolls along. Any member who's had or will have a change in benefits. I know that there are a whole lot of folks on the call today who have ANOC as part of their key responsibilities in a given year. Members who have recently experienced a change in benefits, or those members that you know are going to, because you're about to issue an annual notification of change to those members about their benefits, are going to be the ones who are likely to show up dissatisfied on any kind of member satisfaction survey, particularly CAHPS. And what we can do is we can also identify through using our proprietary benchmarks and our predictive analytics to identify members who are likely to churn. Members who are most likely to churn away from your program or your plan, as I mentioned before, are just as potentially destructive or damaging to your star rating as members who are going to be dissatisfied and stay. But one note, we'll talk here in a minute about some of the best practices that we borrowed from that we at Icario borrowed from other consumer-facing industries, like the likes of member marketing loyalty campaigns in Starbucks and Delta Airlines and the like. One of them that we apply here is an omni-channel approach, and I know that a lot of plans are worried, rightly, about member abrasion with regard to the multiplicity of messages that you put in front of a member at any given time. By our estimates, your health plan probably reaches out and touches an individual member north of 250 times a year. And so we are uniquely aware of and hyper conscious of member reparation. But the use, throwing the baby out with the bathwater of ratcheting down and doing a single channel to do outreach in a pre-CAHPS survey or other types of member engagement activity is tantamount to cutting off a piece of your membership who may only have one channel that for which you have solid information. So if all I have is a mobile number and TCPA has scared you off and you're not reaching out to membership using SMS, then you will not reach me as an individual who only has one mechanism by which I can be reached. In the opposite, with your Medicare Advantage population, what we find is that the omni-channel approach takes on a different flavor, particularly with a Medicare Advantage aged population. If I receive a text that says my health plan is asking me to do something, I might regard that text message as a scam. I might be wary of it. But if I receive the same message with the same branding, with a similar call to action across a multiplicity of channels, and maybe even those multiplicity of channels are self-referential, where they're referring to, we're sending you a text to letting you know that you'll be receiving a call, my barriers come down and my likelihood to engage goes way up. And ultimately my satisfaction with the plan and their outreach to me goes up as well, because now it's not abrasion, now it's me, my barriers to trusting in those messages come down and my trust goes up. We also take the approach that it's not necessary to reach out to everybody. As we talked about our targeting criteria before, what you noticed was the absence of trying to be all things to all people and reach out to everyone. We figure that in a rewardable type of member satisfaction program, while CMS requires, and we are compliant with, 100% of that population to be eligible for the program. Usually about 30% of your overall population is where we end up targeting with a pre-CAHPS survey, because between a combination of what you already know and our predictive analytics, we can identify those populations that are most likely to be dissatisfied and most likely to churn and target those individuals for the sophisticated outreach while making the entire population eligible for the program. Some of the things that we use in order to determine that targeting criteria are third-party data that, like I said before, other member marketing loyalty programs like Delta Airlines and Starbucks use. We happen to use it in such a way that it is pertinent and germane to a healthcare audience. So we can identify members' age and gender and behavioral data, their email status, their zip code, their likelihood to vote. We can identify whether or not they are survey takers, right? So if you're issuing a pre-CAHPS survey and you can identify a population that is more likely to take a survey, that is obviously they're more likely to engage with the program. What this teaches us, or what this has shown us over time, is that there are sort of precursors to membership that is likely to stay versus those who are likely to churn. And we have found in our experience that members are less likely to churn away from your plan if they have higher income. They are less likely to churn if they live in more affluent demographic areas. They are less likely to churn if they have longer tenure, longer length of residence at their primary address. And they are less likely to churn, this is a weird one, if the plan has an email address on file. If you have an email address on file, members are less likely to churn. All of this speaks to the approach that we take that applies these tenets that have long been part of consumer marketing and apply them to a healthcare space, using a very fancy term called operant conditioning, which really all it boils down to is that we're reinforcing and shaping health-related behaviors over time, right? We are conditioning members to do things that are good for them over time, not trying to do things as one and done. I often say, member engagement, like pre-CAHPS, member satisfaction, like the results you've seen in a CAHPS survey and a retention program, are not an event, they are a process. It's not a sprint, it's a marathon. And some of the things that we borrow is that we target behaviors, like we talked about before, that are quantified prior to the program's initiation, meaning what is the priority order of things that you want a member to do? In this case, take a pre-CAHPS survey and give you good responses. Those are the prioritized order of things that we do in program design, because we find that members complete the activities we ask them to complete in the order, the prioritized order that you, the plan, says they should complete them. It is a little bit of psychology that we build in. We break complex behaviors down into simple steps. So we don't try to give the whole of any program call to action to a member. What we try to do is engage them in the program first. And once they raise their hand and say, yes, pick me, then we start asking them to do the activities that we're wanting them to do. In this case, take your pre-CAHPS survey. We time when we're lucky enough to do rewards and incentives in a program design, we time the reinforcement, in this case, a reward or incentive, as closely to the occurrence of the targeted behavior as possible. Delayed gratification is not a core tenet of member satisfaction. Immediate gratification is a huge motivator. And so if you're hanging a $10, $15, $20 reward in exchange for participation in the pre-CAHPS survey type of setup, tying that reward to a member self-attestation as opposed to waiting to see the results in your analytics that a member has completed that that survey and then issuing a reward is tantamount to greater member satisfaction. And then individuals achieve steady engagement through multiple learning trials, meaning, this is what I was saying before, doing a pre-CAHPS survey and then analyzing the data and then putting a program in place and then delaying the reward and incentive is too long a runway, too long a time frame to be effective for what you're trying to do, which is improve member satisfaction and retention. Instead, the real-time data exchange that can occur between while you are receiving Cory's pre-CAHPS survey data, that you have a program in place to act on based on the finite and knowable types of parameters that might cause Cory dissatisfaction, mean that the second that you get my feedback, you can be deploying the very campaign that is meant to address my dissatisfiers on the back end without the delayed input and analysis and gratification that are likely to cause even further member dissatisfaction. That's exactly what we did. This is just a little tentpole in what we did for a large Midwestern Blue plan over the course of a couple of years with regard to their member satisfaction and their CAHPS scores. So between year 1 and year 2 in 2 large H contracts, their CAHPS scores went from a 4 to a 5-star and a 3.5 to a 4.5 star by deployment of the exact model that I was talking about, which was a pre-CAHPS survey that was a real-time data feedback to the health plan with a program sitting at the ready that they could execute against dissatisfiers in order to meet those member dissatisfiers, address them in real time, and move meaningfully forward ahead of the formal CAHPS survey and AEP. I'll turn it back to Andy to bring us home.
Great. Well, thank you, Cory. As we showed this at the beginning and now at the end here, you are here, right? July 10th, 2024, right? Right now you're focusing on, what are we going to do here as we think about AEP? What are we doing for next year's CAHPS scores? Hopefully you have a plan in place. Hopefully you're able to get that information, but if not, we can help. We're happy to eat and eager to jump in to work with you to understand what are those challenges you're facing, what are those different type of engagements that you need to make with members. How do you think about health equity index and the downstream impacts to your operationals? We are here to help support and drive home member satisfaction to increase that component of your overall STAR score and make sure that your members are feeling wanting more as they head into their annual enrollment period. So I think now, Cory, we're going to open up if there's any questions from the group.
And just a quick bit on the Q&A. You all have access to the webinar chat. If there are questions, please toss them in the chat. We're happy to take a minute and let you compose those for a second. And if there are any questions, we're happy to address them. In addition, I will add, while you're composing your questions, one of the questions we get frequently is related to when will this webinar be available. The team running the webinar this afternoon tells me that, barring any technical issues, we should have this back to you in a recorded format by week's end. So by Friday afternoon, you should have this available to you as the recorded webinar. So if there are any questions, we'd love to hear from you.
Here we go, Corey. You see this?
I do. I see. What are examples of the earn to members based on what CMS allows? Are they gaps in care focused incentives? Thank you, Michelle, for the question. The answer is the latter half is yes. So gaps in care focused incentives are typically what we deploy in a member satisfaction type of program. So some examples are we tend to pick on the ubiquitous types of activities that apply to virtually any member and augment them with some additional learn and earns in order to sort of create a comprehensive program. So some of the gaps in care focused incentives, like you're intimating here, annual wellness visit, annual flu shot. We lean heavily then into things like the Haas measures, because while they may not show up specifically on the CAHPS survey, they will show up in the Haas survey. And if we're prompting a member to get an AWV and there are no other underlying conditions, those types of discuss with your doctor, risk of falling, bladder control, and so on, tend to be additive to that AWV and are positive influences to getting those conversations started. As I mentioned before, the other added benefit, particularly related to incentives, is when you incent a member, they are more likely to remember that they did it. Moreover, the types of materials that we're sharing with a member on an ongoing basis, up to and including the member portal that they can see everything that they're eligible for, includes you completed this activity. So, and then finally, what we'll do is on the inbound to that AWV with their physician, we will remind members and send them and share with them a checklist of here's the stuff to talk about with your primary care physician in order to make that AWV as productive as possible.
All right, Corey, we got another one here. What is the number one thing we can do today to help influence CAHPS? Man, that's I just want to say it depends. I mean, the biggest thing, right? I think the number one thing you can do to influence CAHPS is to do a pre-CAHPS survey. Understand what are the challenges and opportunities that your members are facing. Without that sort of level of data and insight, you're kind of shooting blind. I don't say there's exactly one thing that's going to solve a member satisfaction, because it could vary. That being said, there could be one key theme within your population. We've seen that from customer service. We've seen that in different specific provider networks where there's a theme in which members often repeat waiting more than 15, 30 minutes for their appointments. But you don't know that without getting that data, without reaching out for their opinions first. So first and foremost, start with the survey.
And I'd add to that, it's probably going back to that discussion that we had earlier, which is if this is the mindset that your plan or your senior management has, that CAHPS is an event, that CAHPS is a monolith and a thing unto itself, to start to push up against the boundaries of that and start to understand that there are influencers beyond CAHPS that are deeply informative and that you can take action on today, that go beyond the answers that you're receiving with the CAHPS survey, the insights that Andy shared as he was working through, particularly related to activities of daily living, identifying other variables that are causing members Andy talked a lot about psychology, right? That are causing members strain in their lives that is showing up then in dissatisfiers that they're pinning on you, the health plan, is a great way to get upstream of the actual CAHPS survey. So understanding what other underlying conditions like ADLs, like social determinants, utilizing the full scope of those touch points, like I said, north of 250, those touch points that you're having with your membership, to identify beyond the simple answers to the CAHPS survey, where your members might be experiencing dissatisfaction, will give you much better early warning signs than the results that you're about to receive on the back end of the formal CMS CAHPS survey ever will.
All right. Any other questions?
Give it a beat here.
Yeah, and of course, as if you're if you're multitasking and having a hard time typing your questions, be happy to answer any questions in a call. Email sometime. We can talk through what are your CAHPS strategies today, tomorrow, what challenges exist today with your current operations around CAHPS and member engagement.
All right. Seeing no additional questions, like Andy just said, we'd invite anybody with follow-up to contact us directly. Otherwise, if after the end of the week you have a chance to re-review the recording of this this webinar and that spurns additional questions, we're happy to follow up on those as well. Otherwise, thank you very much on behalf of everybody at Icario, on behalf of my friend Andy, Lee, and I. Thank you very much for your time and attendance, and we'll give you about 10 minutes back before the top of the hour. Thanks.
Thank you, everyone.